A 10-year-old girl presents to her pediatrician for a checkup. She reports mild bilateral leg pain when she walks quickly or runs. Vital signs show blood pressure 144/82 in the right arm and 148/84 in the left arm, but only 98/45 in the right leg and 96/44 in the left leg. On physical examination, palpation of pulses reveals brachial femoral delay. In which of the following genetic syndromes is this patient's condition most common? Option A, Noonan syndrome. Option B, Turner syndrome. Option C, Alagille syndrome. Option D, DiGeorge syndrome. Option E, Marfan syndrome. Take 10 seconds. Upper extremity hypertension, lower extremity hypotension, brachial femoral delay, and exertional leg claudication in a young girl. This is coarctation of the aorta, a fixed obstruction of the aorta distal to the left subclavian artery. Which genetic syndrome is most classically linked to coarctation of the aorta, especially in girls? The correct answer is B, Turner syndrome. This patient has coarctation of the aorta. The obstruction of the aortic arch distal to the left subclavian artery causes high blood pressure in the upper body and low blood pressure in the lower body, with brachial femoral pulse delay. The most common genetic syndrome associated with coarctation of the aorta is Turner syndrome. 45x. Approximately 5 to 15% of girls with COA have Turner syndrome, and up to 18% of patients with Turner syndrome have COA. Because of this link, all female patients diagnosed with coarctation of the aorta should undergo genetic testing, specifically karyotype analysis. Noonan syndrome most commonly causes pulmonic stenosis. About 80% of Noonan patients have cardiac defects, but COA occurs in fewer than 10%, making Turner syndrome a much stronger association. DiGeorge syndrome, or 22q11.2 deletion, is associated with conotruncal defects such as tetralogy of Fallot, truncus arteriosus, and interrupted aortic arch. COA can occur but is not the classic defect. Alagille syndrome is most commonly associated with branch pulmonary artery stenosis and hypoplasia. COA has been reported but is much less likely. Marfan syndrome causes aortic root dilation, aortic regurgitation, increased risk of aortic dissection, and mitral valve prolapse. Coarctation of the aorta is not a typical finding. Key testing point: coarctation of the aorta presents with upper extremity hypertension, lower extremity hypotension, brachial femoral pulse delay, and exertional leg claudication. The most common genetic syndrome associated with COA in girls is Turner syndrome. All female patients diagnosed with COA should undergo karyotype analysis. Remember, Noonan equals pulmonic stenosis, DiGeorge equals conotruncal defects, and Marfan equals aortic root dilation. Follow for daily board questions.